Hello, and welcome to today's webinar, Substance Use Interventions for Adolescents and Transitional Age Youth. I am Hildy Cohen, and I will be the moderator for today's event. This webinar is produced in partnership with the ATTC Network Coordinating Office, AMERSA, and the Adolescent SBIRT project by NORC at the University of Chicago. This webinar is a part of the Transitional Age Youth webinar series. I encourage you to sign up for these other titles: The Impact of Substance Use on the Developing Adolescent Brain, Who's Doing What? The Epidemiology of Adolescent Substance Use, and Integrating Grief and Loss Conversations into the SBIRT model. You can access everything for this webinar at the website on your screen, now and in the future. That URL is sbirt.webs.com/adolescent-interventions. Our team will also send you a follow-up email later today that includes links to the PowerPoint slides, on-demand recording, a brief survey, and instructions to claim your free CE certificate. This webinar is approved for 1 CE through NADAC. You can access the PowerPoint slides through the Handouts pane of your GoToWebinar control panel on your computer or mobile device, or you can download them from the website. You can ask questions at any point in this presentation through the chat pane of your GoToWebinar control panel on your computer or mobile device. Answers will be posted on the website. We have two expert presenters with us today. The first is Dr. Sarah Bagley. Dr. Bagley attended Georgetown University School of Medicine and then completed a combined internal medicine and pediatrics at Brown University and an addiction medicine fellowship at Boston University School of Medicine. She is the founder and medical director of Catalyst at Boston Medical Center, providing integrated substance use care and primary care for patients less than 25 years old. She was one of the recipients of the 2017 10 Outstanding Young Leaders from the Greater Boston Chamber of Commerce. Her research focus is on the engagement of young adults who use drugs and their families in care to minimize risk for overdose and the complications of drug use. She has funding from the National Institute on Drug Abuse and the Boston University School of Medicine, CTSI, to conduct research about engagement in treatment and overdose prevention of young adults after non-fatal opioid overdose, stigma related to medication use for opioid use disorder, and engaging women who use drugs in research. Our second presenter is Dr. Nicholas Chatty, who is a pediatrician specialized in adolescent and addiction medicine. Dr. Chatty recently completed a Master's of Public Health at Harvard University and was the first pediatrician in North America to complete a pediatric addiction medicine fellowship at Boston Children's Hospital. His research focuses primarily on the prevention and treatment of nicotine and cannabis use and addiction among adolescents and young adults. So without further ado, I will pass the presentation to Dr. Chatty to get us started.
Thank you so much, Hildy. It's a pleasure for us to be here today and speak on such an important topic. So Dr. Bagley and I don't have any conflicts of interest to disclose. Let's just dive right in with our objectives for today. So first, we'll start with describing the steps involved in conducting screening, brief intervention, and referral to treatment, also known as SBIRT. We'll then go through some key behavioral and medication treatment approaches for youth with substance use disorders, and close it off with discussing the role of family and community support in caring for youth with substance use disorders. So for part one, the part that I'll be presenting, we'll speak more about screening and behavioral interventions. But before we go any further, let's talk about a clinical vignette. So let's meet Cynthia. She's a 14-year-old grade 9 student. She started vaping 2 years ago, and she says that she uses high concentration, pre-filled, disposable flavored nicotine and THC vaping devices. She vapes before, during, and even after school. And she wakes up once or twice every night to take a few hits of her vape. She tells you I just love how social vaping is. All my friends do it. The only problem really is that I do it so much, I kind of don't want to do anything else. So what are some of the things you would like to know? What else would you like to know about Cynthia's substance use behaviors? And how could you help her cut down or quit? Hopefully this presentation will help you answer some of those questions. So when we think about substance use disorders throughout the life course, there are many similarities with other chronic health conditions. When we focus specifically on adolescents and transition age youth, we're really thinking about early interventions and what I like to think about as bending the curve of the disease. So by identifying very early on or even preventing substance use behaviors, we can prevent them from increasing to the point of reaching the threshold of substance use disorders. And there is a great advantage of doing that compared to intervening much later in the life course. And so hopefully by the end of this talk, you'll feel better equipped, or you'll learn a few things about how to intervene early with young people to identify what might be the issues and then provide appropriate care and interventions to help intervene earlier in the course of substance use. So a few words about SBIRT. Some or many of you may be familiar with the acronym, which stands for S, screening, using universal or targeted screening to assess the use and the severity of use of alcohol or tobacco, marijuana, illicit drugs, and prescription drug use and or disorders. And so this is usually done using validated screening tools or short questions that have been proven to have high yield to identify problematic use of substances. Then BI for brief intervention, the next step. So an interpersonal interaction with a primary motivational impact that really is aimed at triggering change and decision making in the own person to help them find their motivations for change. And that can be very brief. And then finally, RT for referral to treatment. So when necessary, and we've identified problematic substance use, referring to specialty care or the appropriate substance use resource. So I'll talk to you a little bit about SBIRT in Massachusetts. I was in Massachusetts when the state enacted a law requiring all schools to offer SBIRT to middle and high school students. That took place at the end of the 2017-2018 academic year. And at the time, that was quite new, as it was the first state in the United States to have such a policy. So in school, at least once during the duration of middle or high school, students would meet one-on-one with a school counselor, a nurse, a psychologist, or another school staff to see if they had any substance use or problematic use. And so being there when that was happening, my team at Boston Children's and I were very curious to see, well, what do young people think about SBIRT? And you know, is this a good idea? We were very happy to hear that school SBIRT was generally well accepted by students. That was true both for students who had initiated substance use and those who hadn't yet. Although students who had started using substances were a little bit more reluctant about sharing about that. We found that the majority of students do value speaking with an adult about substance use and would feel comfortable following up with the screener. And our sample was large enough that we think that the data is fairly robust. And there were, even though young people did feel comfortable speaking about this and engaging in SBIRT, several barriers to disclosure. And the best way to address this really is an ongoing question, but we know that there are a few things that we can do as providers, as school staff to make young people more comfortable with this type of discussion. And I'll go through this in a minute. So this is just a schematic representation of SBIRT and the 3 different steps. So I mentioned as a first step, using a validated screening tool to identify risk levels and find appropriate interventions. So there are several evidence-based screening tools, and I'll get to this in a second. But before we even start talking about substance use, it is so important to address privacy and confidentiality. So with every young person, we should be thinking about identifying what are the limits of what's being said in terms of confidentiality. Who's going to hear this information ultimately? So this really should be at the beginning of the visit and done in a way that would encourage young people to be honest and truthful. We can tell them that we will also be honest and truthful with them and encourage them to do that. And we want to create a safe space where youth will feel as comfortable as possible to share sensitive information. And that might require a closed space, a closed door, knowing that we won't be interrupted, and others. And so we want to be clear about reasons where we might want to breach confidentiality. Example, telling parents, and those usually go around situations where there's self-harm or suicidal thoughts, harms to others, or sexual abuse, or in the specific context of substance use that would be so severe that we'd be concerned about the safety of the young person. So once we've established that, we can choose one of the several different evidence-based screening tools. And I've listed 3 here. The first 2 are readily available online. And so young people can do them themselves, or they can be administered by a health provider, and we can simply type those titles in Google and fall right on it. And they are brief, and they have a very high yield in terms of identifying problematic substance use. The third one, the CRAFT, is also an excellent tool translated in several different languages. So for today, I'll focus on S2BI and CRAFT, both tools that were developed in Boston with some of my colleagues or previous colleagues. So screening a brief intervention is my favorite because of simplicity. It is really a single question screening tool, which consists of asking, in the past year, how many times have you used, first question, nicotine or tobacco products? And we want to elaborate and say, this includes cigarettes, electronic cigarettes, or e-cigs, or vapes. And then we wait for the answer. Answer choices should be never, once or twice, monthly, or weekly. And based on that response, we'll be able to associate that with a level of risk of having a substance use disorder or no problematic substance use disorder. We'll ask the same question for alcohol and marijuana. And those being the 3 main substances or most commonly used substances by young people, we can stop there if we get 3 negatives. But if we do get positives on the first 3, we may want to ask follow-up questions with other substances to get a better picture of what's happening in the young person's life. So screening in the brief intervention I mentioned is very nicely associated with level of risk of having a substance use disorder. So if a young person identifies use weekly or more, there's a high chance that there is a severe substance use disorder related to that substance. That's been shown by research done by Dr. Levy and her team and others. And so very simply, we ask the one question for the 3 basic substances. We have a sense of whether or not the substance use is problematic. And we can ask that question verbally or orally, and we can also ask young people to self-report it. So that's the first tool. The CRAFT was the tool that was adopted in Massachusetts for the statewide SBIRT and is still in use, and consists of it's a 2-part questionnaire. So the first part is very similar to what's asked in S2BI, asking in the past 12 months how many times a young person who's used alcohol or marijuana, and then anything else to get high, and then as the last question, tobacco and nicotine. This is in the 2.1N version of the CRAFT that's available on the CRAFT website. So for CRAFT, whenever possible, self-administration using pen and paper or electronic formats usually improve response and disclosure rates. So those are definitely suggested main ways of administering it. So after part A, we move into what gave CRAFT its name, 6 follow-up questions based on the letters C, R, A, F, F, and T. And so if we've identified some use of substances, we'll want to ask all of those questions. If there was no use, we can stop after the car question. Have you ever ridden a car driven by someone, including yourself, who was high or had been using alcohol or drugs? And then if you get a yes or a no to this, you can do a bit of a counseling intervention and move on. If there was some substance use, you want to ask the other follow-up questions to see if there was an impact in everyday functioning related to the use of those substances. So use to relax, use alone, use that led to forgetting things, problems with family and friends, and getting into trouble. And just like S2BI, CRAFT has a nice correlation with the risk of having a substance use disorder as per DSM-5, this big book of mental health disorders criteria. So you'll see that if there's a positive answer for 4 or more of these CRAFT questions, there's a very, very high chance that the young person has a substance use disorder. And so CRAFT also provides some speaking points for a quick follow-up discussion that can be based on the answers obtained from the screening questions, and is really sort of meant to be a take-home tool. So we hope that young people will be truthful and disclose their use using these screening tools that are either self-administered or administered verbally in a session. But we also want to think about other risk factors for substance use disorders. And I've illustrated a few here, and all of these are things that can predispose youth not just to substance use, but to problematic substance use or substance use disorders. So the numbers in red with AOR for adjusted odds ratio are meant to indicate the increase in odds of having a substance use disorder if these things are present. So an odds ratio of 1 keeps you to an average level of risk, and everything above 1 is an increased risk. The only number here that's under 1 is for younger age. So every year you age, the lower you age before you start using substances, the lower your risk of having substance use disorders in the future. But for all these other elements, so being exposed to marijuana, smoking cigarettes, being prescribed pain relievers, using pain relievers not for prescription, using medications recreationally, all of those things will increase your odds of having a substance use disorder later on in life. And there are several other mental health factors that we might want to think about, and family factors, so family history of substance use. So if we can't get, or we have the feeling that we're not really getting the answers we're looking for with the screening tools, we can also think about risk factors that might help us with the next steps of SBIRT, and the immediate next step, the brief intervention. So coming back to this schematic, we've used our validated screening tool. We've identified the level of risk. So if there's no use, we'll want to give positive reinforcement, saying that this is definitely the healthiest thing that young people are doing, not to use. If there's a bit of use, but not meeting criteria for a disorder, we can continue reinforcing and sharing some of the health risks of using more. But if there is mild to moderate or even severe substance use, we'll want to think about speaking a little bit more and using motivational interviewing. So there are different frameworks to think about structuring a brief intervention. And the 5 A's model is a model that you might have heard about that I like, that has been used in tobacco cessation. And so once you've screened and identified some substance use, you may want to ask some clarifying questions about the use of the different substances, setting, frequency, intensity, things that young people like or dislike about their use. And then a very important part is giving a clear message, advising young people to quit as the healthiest thing they can do. So a message like that coming from a health provider is definitely helpful and can go a long way. Then you'll want to get a sense of where young people are in terms of thinking about potentially reducing or stopping their use. And you can use a readiness scale for this, like on a scale from 1 to 10. How ready are you to make changes? And then you'll want to think about ways to assist the young person. It could be using non-pharmaceutical or behavioral means or pharmaceutical means, which we'll talk about a bit later. And you'll want to close your brief intervention with a follow-up. Could be with yourself or with another provider, depending on what's available and what's indicated. So just some very quick points about this brief intervention I'm talking about. We really want to think about using a patient-centered and a strength-based approach. Adolescents, like adults, but this is very specifically important in adolescents, like to be considered as people with interests and strengths. No teens like to be thought about as problems or issues. So even though we are talking about substance use, we want to elicit some positives. They might be into sports, and you can want to comment on something they're wearing, or something they've done if you know that about them. And that can set a tone for the brief intervention that's already lighter and more positive. As I mentioned, we'll want to advise cessation, knowing that for some youth that's not a viable option short term. But we will want to say still that the safest option is not to use. We'll think about providing some, but not too much information about health consequences related to substance use. You've heard about some of those if you've listened to the 2 previous lectures of this series. We'll want to use a non-judgmental approach, and that really is for all discussions, to try to elicit a discussion on even ground. And as I mentioned, thinking about readiness, but also willingness scales from 1 to 10 and commenting on the response can be helpful. So a young person can say, well, I'm about a 5 out of 10 thinking about decreasing my use. Well, you might want to ask, why is it a 5 and not a 3? Or how can we get it to a 10 or a 7 or a 6? So Motivational interviewing, as I said, is a discussion style that's really based on having people come up with their own solutions. And it is based on the different stages of change that I've illustrated here in the little schematic. So we really want to take young people from a point of being pre-contemplative, thinking, no, I'm not ready to make any changes. This is what I'm doing and this is staying, to, well, contemplation. Well, maybe I could do this, and then to preparing. So how or what do I do now, to an action phase, and then maintenance. So progressing through this cycle may take several sessions and several brief interventions or follow-up, but this is really what we're trying to do. And it's normal that young people would have ambivalence around change. And ambivalence is really something that we see in all people for change, is true with substance use, especially if there's dependence or addiction to different substances, or benefits that young people see with their use. So we'll want to help young people to find their own reasons to change and think about the advantages that might help them to get there. And so there are several different tools in what I call the motivational interviewing, or MI toolbox. And going through those in detail would be beyond the scope of this lecture, but a quick conversation that uses more open-ended than closed-ended questions definitely stimulates discussion. So asking what and how instead of yes/no questions. Using reflective listening, show that we paid attention to what the young person said. So you told me that you enjoy this about your use, but not so much that part about your use. So using what young people have said and reflecting this back. We'll want to affirm things that we hear and that might be helpful. So young people may be very skilled at sports or in school, and we can affirm that and say that, based on their strengths, they, show determination and can use that determination for cutting down or reaching their goals with substance use. As I mentioned, some young people are not quite ready to cut down or quit, and negotiating or finding some kind of compromise or thing that's manageable is something that can be very helpful. Reframing or offering a different perspective. Sometimes young people don't see or find their use as problematic, but maybe their parents do, their friends. If they try to put themselves in other people's shoes, that might change their view a little bit. And then closing the discussion with a bit of a summary, especially if young people came up with some reasonable or realistic options that they could go for in terms of reducing their use or quitting. So coming back to our little algorithm here, when we've uncovered use that's a bit more severe, and we think that there's definitely referral to treatment needed for additional resources, we'll want to think about what's available and what's possible. So illustrated here is a continuum of care. I find it helpful to look at the different levels of intensity when it comes to substance use services for young people. And so, at the top, we have the more population-based preventive intervention, so school programs, parent education, peer mentorship, and recovery groups, things that are available to everyone really, and that should be kind of the foundation of trying to prevent and bend that curve of substance use in young people. Then early interventions that can be done in primary care or in schools is a little bit what we were talking about, doing SBIRT and doing this motivational interviewing discussion. Some young people need a little bit more. They'll need outpatient follow-up with some specialized mental health resources or counseling groups, which can be done individually or in groups, sometimes virtually now, given COVID and circumstances. Family therapy can be helpful. And in some cases, medication-assisted treatment can be something that can be supportive for young people with addiction or severe substance use disorders. And Sarah will tell you about this in a little bit. Some young people still need more, and a weekly session or appointment will not, be sufficient to help them. And so intensive outpatients or partial hospitalization programs that give several hours of support a week might be something that be considered. And this sort of takes us to some more intensive means with clinically managed or non-clinically managed residential or inpatient programs that can really take the youth outside of their setting and help them get some support for their use throughout the day, and give them some tools to reduce their use or quit using more long term. And in some cases, acute inpatient or withdrawal service or crisis stabilization programs are needed. So before I pass the baton to Sarah, I'll just focus on some of the known behavioral approaches, apologies, sorry, that are used with transition age youth and that have some evidence base behind them. And so I mentioned motivational interviewing, which really should be seen as kind of our first line, the bulk of what inspires our discussions with young people when we're talking about substance use and addiction. So I mentioned motivational interviewing is more of a conversation style that helps young people come up with their own motivation for change. Some of you may be familiar with cognitive behavioral therapy, and that can also be used in the context of substance use. In cognitive behavioral therapy, or CBT, really relies on understanding the associations between behaviors, such as using substances, the emotions that are triggered or that lead to that use, and then how that all connects with different thoughts. And so untangling these sort of cycles and associations can help young people see why and how they use substances, and why and how they could maybe change some of their behaviors or think about things a little bit differently to help them with their goals and achieve progress with their substance use. Dialectical behavioral therapy is a different type of approach that can work well with young people that have severe distress related to mental health and or substance use, and really will help young people connect this sort of emotional mind with a more reasonable and rational sort of mind to try to reach what is called the wise mind. And through the process of DBT, learning skills like mindfulness and distress tolerance, and this can be done in groups or individually, and can be helpful and very helpful with young people with borderline personality traits, for example. And finally, contingency management can be an approach that is very helpful for many substances. It's been studied and shown that for stimulants, for example, substances that don't, like stimulants like cocaine use or non-prescription stimulant use that don't really have approved medical approaches like medication to help, giving positive reinforcement. So there's a behavior, so not using, being able to not or cut down on the use, and then thinking about a reward. It could be a reward system based on monies or concrete things that young people are working towards, can help with sort of a action and consequence that can be positive or negative. Some kids maybe, or teens might function better with all right, well, they really want to drive, but they need to be not using substances to get there, and if they don't, perhaps we'll think of delaying the use of a car and things like that. So finding sort of ways or systems based on behaviors with some positive or negative consequences that can be done in a more formal setting, or a bit more informally discussing with the family, with the young person, is a way that can be helpful to support youth with substance use disorder. So kind of a quick overview of the different approaches that can be used behaviorally, of course, and delivered by providers and professionals, with the support of definitely different spheres of a young person's life, so school and family and activities. And I'll stop it here for this part of the talk and pass it to Sarah to tell us a little bit more about medications and family and community support.
Great, thanks so much, Nick. That was a great first part of this talk, and I'm going to take it from here and really focus more, do a deeper dive into some of the medication options that we have for treatment of substance use disorder, and then touch on family and community support that we know are so important as we're caring for youth who are using drugs. And so I think it's always helpful, just like in the first part, to start with a case to ground us. So here's Ben. So Ben is a 19-year-old. He's a sophomore in college. He's known to have anxiety and ADHD that was diagnosed a couple of years ago. In the 10th grade, he started trading his ADHD medication for opioids and benzodiazepine pills that he would then resell at school. Now he's using oxycodone and alprazolam on a daily basis, and he says that it helps keep stress levels down at school for him. He also attends pill parties where he and his friends ingest different pills without really knowing what they do, but it's just part of the scene that he's part of. So the question is, what else would you like to know about Ben's substance use behaviors, and how could you help him cut down or quit? What are our options for supporting Ben? And so what else do you want to know? So when I'm thinking through a case like this, I'm going to lead you through some of the questions that are coming to mind as I'm starting to have this conversation with a young person. So I always start with asking, why does Ben say he's here today? What's brought him in? Does anything sort of happen recently, any kind of crisis that's bringing him in? And it helps me then sort of focus our visit and understand what his motivations and priorities are that are really important for me to have clear in my mind so that I align my treatment plan and sort of options for treatment with what is going to be motivating for him. I also want to know the frequency and sort of dose, the amount of opioids, benzodiazepines, or other drugs that he might be using so that I can also assess his risk of withdrawal. I'm going to ask questions about how he's using these drugs. Is he taking them orally? Is he snorting them? Has he started to inject opioids or stimulants, for example? Does he have a history of overdose? These questions, again, are sort of helping me do a risk assessment in my mind and help sort of make some decisions quickly, potentially in that first visit, to tailor to treatment plans. And then does he think his parents or sort of other close social supports really know about his substance use? Because I think that, as we've heard in some of the prior talks, engaging with families and social networks and friends is really critical, and being able to identify individuals who may be allies in treatment is important. And so figuring that out from the get-go is an important step. So what are our next steps now? So we need to determine the diagnosis or potentially multiple diagnoses, assess the risk to figure out whether or not there are any urgent or emergent decisions that need to be made in this setting, and also identify others who can provide support for Ben. So a word on the diagnosis of substance use disorder. There are 11 criteria that we consider. If a person meets 2 to 3 of them, they have a mild substance use disorder. If they meet 4 to 5, they have a moderate substance use disorder, and 6 or more means that an individual has a severe substance use disorder. When I'm sitting in clinic, you may not have this list in front of you as you're assessing a patient, and so I try to simplify it and really think about the 3 C's. So cravings, loss of control, and whether or not there's compulsive behavior. And if, as I'm asking questions or hearing history from Ben or another patient, that the person is experiencing cravings, really no longer has control of their substance use, and is engaging in compulsive behaviors, then I'm concerned that potentially this person does have a substance use disorder. And then later on, I can actually sort of go through the criteria and try to figure out which ones an individual may meet. I want to also point out, though, with adolescents and young adults, it's very possible that they may not endorse any of these criteria and sort of deny that the substance use is a problem, really be in that pre-contemplative state that Nick was talking about. And so I think in those times, I also try to consider collateral information that they may have, other medical records. Maybe there was a history of an overdose, potentially a family member or a friend is able to offer other information about how substance use may be impacting an individual. And I try to integrate that information and those data into any kind of care or treatment plan I might offer for an individual. So in this case, we're going to say that Ben has told us more about his opioid use, and specifically that he's really lost control over the last couple of months. He thinks that his opioid use is starting to interfere with school. He's noticed a drop in his grades, and that's really what has brought him in to see us today. He is concerned. He also reports that he had 1 overdose, and that one of his friends had to give him Naloxone, the antidote for an opioid overdose. So the question then is, what are our options for treatment? And is there pharmacotherapy or medication treatments that we could offer him? Is it indicated in a person who is 19? So the answer to that question is yes. And so our professional organizations, the American Academy of Pediatrics and the American Society of Addiction Medicine, both suggest and recommend that youth who have an opioid use disorder should be offered medication treatment, or at least be able to be referred to someone who is able to offer medication treatment to them. And so what are our options for medication treatment? So there are 3 options. And this picture here shows you the way the three different options work. So we have methadone, buprenorphine, and naltrexone. So first, methadone. So methadone is what's called a full agonist, and it binds to the opioid receptors in the brain and activates those receptors. Methadone works by controlling cravings and also treating withdrawal, and has been used for decades and has been shown to be very effective. Buprenorphine is what's called a partial agonist. It also binds to the opioid receptor, but is less activating than methadone. It also treats withdrawal and also prevents cravings like methadone does. Naltrexone is an antagonist or a blocker, and so it blocks the effect of any opioids that a person may use. Just going to go into a little bit more detail about these three options. So methadone is available in pill, liquid, and wafer forms. It's most commonly is dispensed as a liquid. It's given daily at an opioid treatment program. These are federally qualified or certified programs, and methadone for treatment of an opioid use disorder cannot be prescribed by a primary care provider in the community. You have to go to an opioid treatment program to receive methadone, and is most commonly given to people who are 18 and older. It is very hard to receive methadone treatment if you're under 18. Buprenorphine is administered in a pill or film most commonly, although there's been an implant and also an injectable form that has been approved in the last couple of years, and the injectable form especially is starting to gain some traction and is being used more commonly. And in order to prescribe buprenorphine, prescribers, so MDs, NPs, and PAs, have to complete a waiver course and be able to do this, but this otherwise can be prescribed from outpatient primary care or addiction treatment programs. Naltrexone is in either oral or injectable formulation, and any healthcare provider with prescribing authority is able to prescribe for naltrexone. I do want to point out that naltrexone is approved for 18 and older, and buprenorphine is approved for 16 and older. And so you may ask, though, what's the evidence for using these medications? And that's a really important question to ask before we're going to be recommending any kind of treatment to a patient. And so what do we know? And these data are specific to youth. So we know that there's improved retention and care, and that is true, been shown in both clinical trials and also observational data. We also know that there are decreased opioid positive urine drug tests. This has been shown in clinical trials. So we know youth are using less opioids when they're on medication treatment. There's also improved mortality. So these medications are life-saving. This has been shown in observational studies, mainly in adults, although they include transitional age adults, 18 to 24-year-olds. And so the evidence is pretty compelling that these medications both help to retain people in care and reduce drug use and save lives. However, transitional age youth and adolescents have poor retention in care. I want to highlight, though, that although these medications are effective, that we are still not doing a great job in ensuring that youth have access to these care. So this is a study done by colleagues at Boston Medical Center looking at a group of youth who were insured by Medicaid and had a diagnosis of an opioid use disorder. And they found that only 1 in 4 youth received treatment within 3 months of diagnosis. So only 25% of youth who had a diagnosis of opioid use disorder received medication treatment. Despite this, those youth who did receive a medication treatment were less likely to drop out of treatment and stayed in treatment longer on average. And those bars show you that methadone was actually sort of the best medication and sort of kept youth retained the longest. And that when youth had behavioral services only, they were retained for a shorter amount of time. Even among youth who have had a non-fatal opioid overdose, so a life-threatening event, one study that we did in this last year found that only 1 in 54 youth received medication treatment
in the time after their opioid overdose. And in fact, youth who experienced a heroin overdose were significantly less likely than those who overdosed on other opioids to receive any treatment. So the highest risk youth were not actually receiving treatment after opioid overdose. So we certainly have some work to do to ensure that youth have access to these life-saving and evidence-based treatments. This is just a graph to highlight that there's actually been this widening treatment gap among 15 to 24-year-olds. So these are national data, and it's showing trends in buprenorphine use in the United States, total and by age group. The different bars, the different colors are different ages. And I want to draw your attention to the yellow bar, which is the 15 to 24-year-olds. And what you see is that actually over the last few years, there has been a decrease in buprenorphine use in this age group. Well, in all other age groups, we've seen an increase. And so this is, again, concerning and is highlighting that youth do not have access, or for some reason are not accessing these treatments that we know work. I just want to highlight a couple of the barriers that I think we know exist that may be part of the reason why access to treatment is challenging. So one is certainly that only 1% of buprenorphine prescribers in the United States indicate pediatrics as their primary specialty. We also know that there is both stigma related to having an opioid use disorder, but also the medications that we use to treat opioid use disorder. As someone who's been now treating youth for the last 5 to 7 years, I can tell you I have had many conversations with parents, with family members, with other friends and social networks who have a lot of concerns about the idea of using a medication to treat an opioid use disorder, and a lot of resistance to using medication treatment. And so that is addressing that stigma and really being able to explain clearly the benefits of this treatment is still a task that we really need to focus on. Although naloxone is not a treatment for opioid use disorder, it is the antidote to an opioid overdose. And so all patients who have an opioid use disorder or risk of overdose should be offered naloxone. Naloxone can be given by medical professionals, but also by lay people. And actually 48 states have eliminated the need for a prescription, meaning that in 48 states, you can walk into a pharmacy and through different regulations can ask for a naloxone kit and be given it from the sort of behind the counter. And 49 states allow third-party prescribing, meaning that if I'm seeing a patient and want to be able to prescribe it potentially to a family member, not actually to my patient, that is an allowable thing to do. And finally, this is the last slide sort of focused on opioids, is just wanting to highlight the complications of substance use. And so although the point of this webinar is to talk about interventions for substance use disorder, that there are complications that we should always be bearing in mind when we are thinking about the best care for these patients. So one complication is hepatitis C. So in 2018, the highest rate of acute hep C was among 20 to 29-year-olds. And this was a 300% increase from 2009 to 2018. The same year, 1 in 5 of new HIV cases were among 13 to 24-year-olds. And so just want to suggest this concept that it's really key to integrate HIV prevention and safer injecting strategies for at-risk transitional age youth. So a word on medication options and treatment for nicotine use disorder. So these are approved for 18 years and older. Nicotine replacement therapy, as we would use in our older adults, bupropion, varenicline, and these are all options that should be offered to youth, to transitional age youth who have a nicotine use disorder. There are also behavioral treatments. So certainly giving brief advice, similar to what Nick highlighted in the first part of the webinar. Intensive counseling, quit lines can also be offered to youth. Just want to highlight actually a study that Nick led that showed among 18 to 22-year-olds with nicotine use disorder that fewer than 2% received a prescription, and about 4% received behavioral treatment. So it's another area where we really have a lot of work to do to increase the prevalence of treatment among people who have a use disorder. We also have pharmacologic options for alcohol use disorder, also approved for sort of more the transitional age youth group, not really adolescents. We have naltrexone and acamprosate and disulfiram. They do not require any specific training prior to prescribing, which just differentiates them from buprenorphine. And there are also behavioral treatments. So Nick talked about cognitive behavioral therapy. Motivational enhancement therapy has also been shown to be effective in treating alcohol use disorder. And so for other substance use disorders, such as cannabis use disorder or stimulant use disorder, behavioral treatment is really our main option. I just want to highlight, though, that polysubstance use is the norm. And so even for the patients who may be presenting with an opioid or an alcohol or a nicotine use disorder, that oftentimes they're using other substances, and so really are going to benefit from a combination of pharmacologic treatment and behavioral treatment. And also that there's a high prevalence of co-occurring psychiatric disorders, and that we really, as we're developing treatment plans, should be integrating both the treatment for the substance use disorder and the psychiatric disorder. And best practice would be to offer treatment for both at the same time. So now just to transition to families, oftentimes we hear that addiction is a family disease, it's a chronic illness, and we know that when one person in a family has a substance use disorder, that we hear that parents, grandparents, siblings, friends are all affected. And so one way that we can address that is to really invite families to be part of treatment planning. Their involvement can certainly vary. You may find that some parents, especially for younger patients, may really want to be part of an initial intake and assessment, and may even require parent guidance visits and really to be integrated into the care. As patients become older, it may be that their families may be less involved, but I would suggest that the more that we can involve families, the outcomes are going to be better for even transitional age youth. I want to point out too, though, that the family-based strategies that are evidence-based have really been tested among adolescents and have not really been tested as widely among the transitional age group, which is a limitation, but I don't think should discourage us from, again, inviting families to be part of treatment planning. There are some strategies that are focused on supporting families who are affected by addiction, whose loved ones may not yet want to be in treatment, may be in that pre-contemplative stage. And I think that can be a really difficult place for parents and families to sit, where they have significant concern for a loved one, but that individual isn't ready yet to engage in treatment. And so there are approaches and there are still options for those family members. I don't think we want to ignore them because their health and well-being is important, and because by supporting them, we may actually be able to encourage the person with a substance use disorder to get into treatment. So I'm going to talk about the CRAFT, which is the community reinforcement approach in family training. We can also offer overdose education and naloxone rescue kits to families who may be when the loved one might be at risk for an opioid overdose. And of course, can offer mutual support groups that are available locally and now are really available virtually. And so it's really possible to access these groups and this kind of support throughout the day and night, and in your community or outside of your community. So a word on CRAFT. So CRAFT is a behavioral treatment, and what happens is therapists are trained to help the family member engage the individual who's resisting treatment. And again, so the whole idea behind the CRAFT is you're really trying to work with family members whose loved ones aren't ready yet. And this is done by helping the family member learn how to modify their environment to reward behaviors that promote sobriety and withhold rewards when the individual is using drugs or alcohol. Sort of, this may sound similar to contingency management that Nick was talking about and is really based in some of the same principles. It also involves teaching the family member about using positive communication skills, and the family member will learn about the difference between enabling alcohol and drug use and reinforcing sober behavior, which can actually be very challenging to do when someone is in the midst of struggling with alcohol or drug use. And importantly, therapists will then also support the family member in taking care of himself or herself, knowing that this is an incredibly stressful time. And the craft has been shown to work in adolescent, young adult, and adult populations. I know that I already mentioned overdose education and naloxone prescribing, but it's so important. I thought that it was worth highlighting again, and just wanted to present that, family members are receptive to receiving overdose education and naloxone, and that receipt of naloxone rescue kits increases confidence and security of family members. I think sometimes we hear, well, are family members really going to be ready to learn about overdose? Are they really going to actually administer naloxone if their child has an overdose? And the answer is yes. In Massachusetts, we found that family members reported actually 20% of all the rescues from state-distributed naloxone. And so families should definitely be given this sort of tangible tool and resource, and they are eager to receive it. And finally, mutual help support groups. So there are many support groups for parents and families, and these can be local and they can be national. I think sometimes we hear from families that they would actually rather attend groups that are not in their community because of this stigma. And so I just suggest that providers can become familiar with support groups in their own communities so that they know where to refer. And finally, just a word on community support and some of these guiding principles of recovery. So I've spent the last 20 minutes or so talking about medication options from a very medical model of substance use disorders. And we certainly know that medications are a key tool in addressing substance use disorder, and for opioid use disorder can be life-saving. And I also know that behavioral treatment is also effective and is a key tool in addressing other substance use disorders. However, I just want to suggest too that it's important to remember treating substance use disorders is complicated, and that navigating recovery, especially for adolescents and transitional age youth, is hard. This is the time in their lives when they're trying to figure out who they are. And I think sometimes there can be a risk if we overemphasize their identity as having to do with having a substance use disorder and do not recognize the other strengths that they have as an individual. And so understanding sort of who they are, who their priorities are, what their priorities are is key to developing a treatment plan that will help them address their substance use, but it will also focus on their potential as an individual that has nothing to do with their substance use. And so that is the conclusion of our webinar. I just want to review some take-home messages that we want to leave you with. So first, screening using validated tools is a quick and effective way to engage with transitional age youth about their substance use behaviors. Brief interventions based on motivational interviewing should be considered first-line treatment for substance use among transitional age youth. Evidence-based treatment, including pharmacotherapy, should be offered to transitional age youth, and treatment plans should include families, be tailored to individual risk, and build on the strengths of the transitional age youth. And I'm going to pass it back to Hildy to conclude the webinar.
Thank you so much, Drs. Chatty and Dr. Bagley. This education will directly impact adolescents, and we are so grateful to you both for putting it together in such a concise and usable way. Thank you so much. And as a reminder, our team will send you a follow-up email later today that includes links to the PowerPoint slides, on-demand recording, brief survey, and instructions to claim your free CE certificate. If you would like to access any of these things now before the email arrives, you can do so at this webinar's website. It's sbirt.webs.com/adolescent-interventions. To augment the information provided today, you can check out these additional resources from the ATTC network. And you can also keep in touch with the ATTC via their newsletter and social media. Sign up now for the Messenger monthly email and follow them on Twitter and Facebook. The PTTC network also has a plethora of resources available to support adolescents, as well as a monthly newsletter, the PTTC post and Twitter and Facebook accounts. These are great organizations to stay connected to. And with that, I thank you so much for attending and will now conclude today's webinar. We hope that you have a great rest of your day.